Welcome to the Deep Dive, where we really plunge into topics shaping our world, digging into the science, the history, and the human impact. Some subjects just carry immense historical weight, don't they? Their narratives transformed by, well, relentless science and human resilience. Today, we're taking a deep dive into one of those profoundly important subjects, HIV/AIDS. For decades, it felt like this insurmountable global challenge, but we've seen an astonishing evolution. Our mission here is simple: give you a clear, comprehensive, and frankly fascinating look at the human immunodeficiency virus, HIV, and its advanced stage, AIDS. Think of this as your essential shortcut to understanding the biology, the history, and the truly revolutionary advancements that have changed millions of lives.
Yeah, and it's so important to see HIV not just as a medical story. It's this complex tapestry, really. Science, history, social impact, all woven together. We'll explore its unique biological quirks, the things that make it tricky, and also the incredible progress in prevention and treatment and the ongoing efforts, the global push to maybe even eradicate it one day. It's a story that I think really shows the best of scientific innovation and collaboration.
Absolutely. And just to set the stage, let's start with a sobering fact that really underscores the scale. Since the early 1980s, HIV has infected over 85 million people. And tragically, it's caused around 40 million deaths worldwide. It's truly a modern pandemic that has shaped generations. So let's unpack this. What exactly is HIV? What makes it such a formidable opponent for the body? At its core, it's a virus, right? One that specifically attacks the immune system. And without treatment, it progresses to AIDS.
That's right. And the key here is what you might call an immune system paradox. HIV goes after the very cells meant to protect us, the CD4 plus T cells, or helper T cells. Think of them as the command centers, the generals coordinating the whole immune defense. So HIV is like a saboteur taking out the general, leaving the soldiers confused, fighting inefficiently. And once someone contracts HIV, well, currently, they have it for life. There's no cure yet, though management is, thankfully, worlds apart from what it used to be.
And one of the reasons it's so challenging biologically speaking is that it's a retrovirus. What does that classification actually mean? How does it affect the way it works?
The retrovirus aspect. That's absolutely critical. It means HIV inserts its own genetic material directly into the DNA of the host's cells, your cells. It literally becomes a permanent part of that person's genome. And that integration is why it's so incredibly hard to completely eliminate from the body. It creates these viral reservoirs, basically, hiding spots in dormant cells. The virus can just lie low there, invisible to the immune system, invisible to most drugs, which is why lifelong treatment is essential to keep it suppressed, stop it from reactivating.
That's fascinating and kind of terrifying.
Yeah.
Looking back then, where did this virus even come from? Its origins were shrouded in mystery for a while.
Yeah, the origin story is quite something. We now understand HIV originated from simian immunodeficiency virus, SIV, in chimpanzees. The jump to humans likely happened, probably through handling bushmeat in Central Africa, perhaps early in the 20th century. What's really striking is that HIV was likely circulating in human populations for decades before anyone recognized it. The earliest confirmed human case we know of, 1959. Kinshasa, Congo. So there was this long period of, silent spread before it really exploded onto the global scene in the 80s, made it very hard to get a handle on early on.
Right, that silent spread. So given that, how would someone today know if they were infected? What are the symptoms? How does it progress if left untreated?
That's crucial. And the tricky part is, early symptoms can be really subtle, often just flu-like things, fever, headache, maybe a rash. This usually happens within 2 to 4 weeks of exposure, the acute infection stage. People are highly contagious then, but these symptoms can be so mild they're easily missed, or some people have none at all. Then it often shifts into a chronic phase. This can last a decade, even longer, sometimes with very few noticeable symptoms. And that latency period, historically, that's what allowed it to progress unchecked before we had effective treatments. Without treatment, eventually the immune system gets severely damaged. That's stage 3, or AIDS. At that point, the body is highly vulnerable to opportunistic infections, certain cancers. But, and this is key, with modern treatment, progression to AIDS is now largely preventable.
Okay, that's helpful. And what about transmission? How does it actually spread? And just as importantly, how does it not spread? We need to tackle those myths.
Absolutely vital distinction. HIV spreads through direct contact with specific body fluids. We're talking blood, semen, preseminal fluid, rectal fluids, vaginal fluids, and breast milk. And these fluids need to contact a mucous membrane, like in the rectum, vagina, mouth, or tip of the penis or damaged tissue, or be directly injected, say, via a needle. So the most common routes are anal or vaginal sex and sharing needles or syringes. It can also pass from parent to child during pregnancy, birth, or breastfeeding, though treatments drastically reduce this risk now.
And the misconceptions, the things people still worry about unnecessarily.
Right, let's be crystal clear. You cannot get HIV through casual contact. Hugging, kissing, dancing, shaking hands, no risk. It's not spread through the air like the flu, not through water, not by mosquitoes or other insects, and you can't get it from donating blood. These myths persist, sadly, and fuel stigma. It's crucial to know the facts.
So, given symptoms can be subtle, and knowing how it does and doesn't spread, what's the bottom line for knowing your status?
The bottom line is simple and absolutely critical. The only way to know for sure if you have HIV is to get tested. Recommendations generally say everyone between 13 and 64 should be tested at least once, and more often if you have specific risk factors. Knowing your status, it's powerful. It lets you protect yourself, protect your partners, and crucially, if you test positive, you can start life-changing treatment immediately. There are loads of options now, quick, often free, painless tests, even self-testing kits you can use at home.
Let's talk about the treatment. For years, an HIV diagnosis was devastating, almost a death sentence. But the progress here, it's been nothing short of revolutionary. One of medicine's biggest success stories, wouldn't you say?
Absolutely. A true triumph. We're talking about antiretroviral therapy, or RT. And the core insight here isn't just managing the disease, it's transforming lives. These medicines work by dramatically lowering the amount of HIV in the blood, the viral load. And here's the real game changer, something we call UU. Undetectable equals untransmittable. The goal of ART is to reach an undetectable viral load. That means the virus is suppressed so low, a standard test can't even find it. And the science is clear. If you have an undetectable viral load, you will not transmit HIV to a sexual partner. That's huge, medically and socially. It allows people on effective ART to live long, healthy lives, pretty close to a normal life expectancy.
That UU concept is incredibly powerful. Beyond treatment for those living with HIV, what about preventing new infections? There are more tools now than ever before.
Yes, the prevention toolkit has expanded remarkably. We have several key strategies. Condoms, obviously. Used correctly every single time during sex. Still a mainstay. For people who inject drugs, using clean needles every time, never sharing syringes or other equipment. Then there's PPP, post-exposure prophylaxis.
Right, PP. That's after a potential exposure.
Exactly. HIV medicine taken within 72 hours after possible exposure, maybe through sex, a needle, stick, whatever.
Yeah.
You take it for 28 days, and it greatly cuts the risk of becoming infected.
Okay.
Then there's TASP treatment as prevention. That's the UU principle we just talked about. Taking ART-T keeps your viral load undetectable, preventing transmission.
Got it.
And finally, PEP, pre-exposure prophylaxis.
Pre-AP, that's one taken before potential exposure.
Precisely. Medicine taken regularly before exposure by people who are HIV negative, but at very high risk. Oral pre-AP pills like Truvada or Descovy can cut the risk of getting HIV through sex by about 99%, and from injection drug use by at least 74%. It's incredibly effective. You do need an HIV test before starting pre-AP, and regular testing usually every 3 months while taking it.
Okay, so ART, condoms, PP, TASP, pre-P, a whole suite of tools. And now there's something even newer generating a lot of excitement. Lenacapavir. People are calling it a potential game changer. What's the story there?
Lenacapavir is definitely one of the most exciting developments recently. It's a breakthrough injectable drug. What makes it so remarkable? It only needs to be given twice a year. 2 injections.
Twice a year.
Twice a year. And it provides almost complete protection against getting HIV for people at risk. It's also used to treat HIV in people who already have it, particularly those with resistance to other drugs. The U.S. government, through PEPFAR, just announced a major investment to make it available to up to 2 million people by 2028. They're focusing on countries with high HIV rates, including using it to prevent mother-to-child transmission. There's real optimism, genuine belief among scientists that this could significantly accelerate efforts to end the HIV epidemic.
That PEPFAR investment is huge, and it signals a renewed commitment from a program that's been a global leader for decades. But it also raises questions, doesn't it, about sustainability, about countries managing their own responses. Is this helping that transition or creating new dependencies?
That's a really important question to unpack. PEPFAR's renewed focus on prevention, especially with a tool like lenacapavir, is vital. The cost, while not public, is estimated around $100 per person per year, with the manufacturer, Gilead, offering it at cost for now. Generic versions might come around 2027. The idea is that this kind of potent prevention can drive down infection rates so significantly that countries can transition to owning and funding their own responses. But ensuring equitable access is a massive challenge. How do we get these injections to everyone who needs them, especially in low and middle income countries? We're talking logistical hurdles, healthcare infrastructure, distribution networks, and there's also discussion about how direct government partnerships for buying drugs might affect local NGOs, the groups often doing the crucial last-mile delivery work within communities. It's complex.
Very complex. Now, while treatment is so effective, it's still vital we remember why it's so important. What happens if HIV goes untreated and the immune system weakens? What are those serious complications?
Right, we can't lose sight of the severity. A weakened immune system becomes vulnerable to what we call opportunistic infections. These are illnesses that a healthy immune system usually handles easily, things like PCP, a type of pneumonia, candidiasis, or thrush. Tuberculosis, TB, is a huge one. Cytomegalovirus, cryptococcal meningitis, the list is long and serious. Untreated HIV also dramatically increases the risk of certain cancers. Lymphoma, Kaposi sarcoma, HPV-related cancers like cervical cancer. And beyond that, you can see wasting syndrome, neurological problems, kidney disease, liver disease. It really underscores why early diagnosis and consistent lifelong treatment are absolutely critical. It's the difference between a long, healthy life and severe, potentially fatal illnesses.
It really drives the point home. Shifting gears slightly, there's a fascinating genetic angle here. Some people are naturally resistant to HIV.
Yes. It's quite remarkable. There's a rare genetic mutation called CCR5 delta 32. Basically, this mutation changes the doorway, the CCR5 receptor that most strains of HIV use to enter immune cells. With the mutation, the door is effectively locked. It's most common in people of Northern European descent, possibly, maybe, selected for by past epidemics like plague or smallpox, though that's still debated. And this mutation became world famous because of the Berlin patient, Timothy Ray Brown.
The first person functionally cured.
Exactly. He had leukemia and needed a bone marrow transplant. Incredibly, his doctors found a donor who naturally had this CCR5 delta 32 mutation. The transplant essentially replaced his immune system with one resistant to HIV. It was a landmark case, pure scientific serendipity almost, that proved a cure was conceptually possible and spurred a whole new wave of research.
An incredible story. But despite that, despite RT, despite Pri-Pro-P, despite everything, there's still one major piece missing from the puzzle, isn't there?
Yes, the vaccine. That's the missing piece. After decades of intense research, billions of dollars invested, we still don't have an effective HIV vaccine. Why? Well, HIV is incredibly clever. It mutates extremely rapidly, constantly changing its appearance to evade the immune system. And remember those viral reservoirs. It hides. It makes it very hard for a vaccine to generate broad, lasting protection. It remains one of the biggest challenges in infectious disease research, a huge area of ongoing scientific effort.
What an incredible journey we've taken in this deep dive, from the virus's origins and its complex biology, right through to the truly groundbreaking treatments and prevention strategies that have just reshaped its global impact. It really is a testament to what medical science and human ingenuity can achieve.
The progress is undeniable, you're right. Effective treatment, RT, means people with HIV can live long, healthy lives. And UU means they don't transmit it sexually. That's revolutionary. Powerful prevention like PrEP and now potentially lenacapavir are changing public health fundamentally. But the fight isn't over, not by a long shot. Millions are still affected worldwide, particularly in resource-limited settings. Global health equity is still a major hurdle.
Absolutely. Which leaves us with a crucial question for you, our listener, to think about. Despite these incredible scientific leaps forward, despite renewed global efforts and investment, what are the biggest remaining hurdles, social, logistical, maybe even biological, that we still need to overcome to truly end the HIV epidemic worldwide? And how do we ensure these life-saving advancements actually reach every single person who needs them, no matter where they live? Something to consider.